Okay, Dr. Yasushi, thank you very much. Very elegant presentation. May I call Dr. Satoshi Mogi? Yeah, to talk to us about OCT in bifurcation lesion. Dr. Satoshi is assistant professor in Department of Cardiology in Hamamatsu University School of Medicine. It'll show.
It is coming, don't worry.
Yeah.
I'm Satoshi Mogi, ladies and gentlemen. I'm very happy to have opportunity to introduce our strategy. My topic is OCT-guided PCI, Japanese-style bifurcation PCI. But, okay. As you know, the bifurcation region is comprise 15% to 20% of all PCIs. And it has a worse outcome than non-bifurcation region because there is a risk of peripheral surgery, myocardial infarction, restenosis, and stent thrombosis. OCT is, as you know, a promising adjunctive tool with its unrevolved high resolution. And the resolution ability is 10 to 20 micromillimeter. It is 10 times higher than IVAS. The intercoronary imaging is especially important for left main PCI. The right is a strategy. It was in the JAK intervention, and IVAS and OCT can optimize stent dilatation and apposition. IVAS-guided left main PCI reduce all-cause death, cardiac mortality, and stent thrombosis. So we have to use intracoronary imaging, especially left main bifurcation or major bifurcation regions. And my topic is OCT guide. How to do OCT guide PCI? At the first of this session, maybe there's not so many people doing OCT guide PCI in this area. And you know, our posterior region is not suitable for OCT because we have to do saline injector dye. Of course, CTO is not suitable. And same reason, impaired renal function, the patient have a impaired renal function, we have to use dextran instead of contrast medium due to AKI, due to refrain from AKI. And this is a recently OCT guide bifurcation PCI strategy. After the predilatation, we check the length of the region and the characteristics of bifurcation angle or something like a soft plaque or hard plaque. And we have to ensure that stent length in proximal main branch segment at least 6 or 8 millimeter to accommodate the pot balloon. After stent, we have to check region coverage and expansion stent and stent apposition. But is it enough to check stent dilatation and apposition using OCT? I think it is not enough. We have to aim for more higher. So I'd like to explain Japanese bifurcation PCI style. This is a recent strategy. After crossing both branch, main branch and side branch, we checked OCT for both vessels. After the stenting, after the pot, we check the second OCT to recognize that good apposition, good dilatation. Then we did 3D OCT because we have to recross side branch wire far distal cell to good apposition and to remove the excess strut of the side branch ostium. After recognition of distal cell recrossing, we do KBI and report. And we did final OCT for both main branch. This is a 3D OCT image. Maybe you can use this technology in your catheter laboratory OCT. And the OCT image can show the position of recrossed wire. As you know, proximal recrossing is not good because excess strut make new metal carina, like B schema, and distal guide wire recrossing is significantly achieved using this 3D OCT guidance than angio guidance. Operator think maybe this is a distal cell. However, if we check the OCT, the approximately is only half. So we have to check the 3D OCT image if the side branch is very important. Why strut removal of side branch is important? Because stent strut of side branch ostium correlates side branch narrowing in the future. Above image is excess strut in the face of side branch ostium. Below is no excess strut in side branch. In the future, the intimal hyperplasia is occurred in side branch ostium. So in upper side, in this type of the group, there is more stenotic. And in this group, no stenosis. So we aim this type of PCI. So how to do 3D OCT guide PCI? I will show you two cases. This is a left main bifurcation. As you can see, there is a region 110 type bifurcation. We did OCT. And he was a history of previous PCI. He have a already stent. It looks like acute coronary syndrome, ruptured and ulceration. This is a photo. Proximal left LAD and left main has ulceration and thick fur. It means unstable plaque. So we put the direct stenting to avoid the slow flow phenomenon. After putting the stent, putting the port to the left main. And after that, we did 3D OCT from LAD to back. This is a 3D image. And this is a distal, this is a proximal, and this is a LAD wire. We can see a circumflex recrossed wire. We can see two cells, below cell, above cell. If we dilate circumflex with this wire, this metal going to protrude this towards. So we try to get this cell. If we dilate bad position, if we dilate circumflex with bad position wire, gelled struts are remained in front of side branch. So recrossed more far cell. This is a second wire to circumflex. And do OCT again. So we can see two wire into the circumflex. First wire and second wire. We success to get correct wire position. Then we remove the first wire and dilate circumflex with second wire. Because why I choose second wire? Because first wire is not the correct position. What is after that? This is a 3D image after KBI. Excess strut was removed. Final. Okay. I don't have enough time, so I will cut the second case. Okay. The second case is the same type. So after the pot, we did OCT 3D again. So I'd like to explain this schema. It's very important for 3D OCT bifurcation PCI. After 3D construction of OCT image, we recognize the wire position. Where is the wire? If the recrossed wire is going to distal cell, green is OK. If the second wire is going to blue position, it is not good. Because if we direct with this blue wire, excess strut was maybe affect long-term result. So in this case, like this position, so we direct with shorter balloon. And you know, if we direct side branch with long balloon, contralateral side strut was removed, stripped. So I'd like to use short balloon. We checked no strut deformation at the circumflex ostium. And strut is falling into circumflex ostium. And importantly, circumflex contralateral strut was not stripped. Of course, no strut at circumflex ostium. Left main is a very oval shape. A good final result. So this is in summary. And 3D OCT can visualize the positional relationship between the stent ring and carina, and the guide wire recrossing position through the stent cell toward the side branch. And the 3D OCT guidance, optimal guide wire recrossing to the side branch and better stent position were achieved, potentially leading to a better clinical outcome in the treatment of bifurcation lesions. Ultra-short length balloon dilatation after adequate expansion of the proximal main branch stent provided acceptable acute and long-term results as an alternative to kissing balloon inflation. Of course, you know, a limitation of OCT of the left domain is image interference with blood. Thank you for your attention.
Thank you very much, Dr. Mogi. Yes?
Excellent. Thank you for both speakers. Excellent presentation. Now, when it comes to the distal struts versus proximal struts, so I think it's two issues. Number one, you create more of metal carina. Number two, you take these struts from the lateral wall of the branch. So from your experience, was the stenosis or restenosis, was it due to the carina or mainly in the lateral wall of the side branch?
It's a very important question, and mainly after the single crossover technique, and restenosis may occur main branch ostium or side branch ostium. However, within this technique, we don't have not so many restenosis patients for side branch ostium.
And
sorry, thank you. Excellent presentation and showing how to use the OCT to the ultimate, perfect way. Tell me, how long does it take, or how much experience do you need to be able to interpret these images, and how long does it take to do it? Because I'm thinking of a cath lab with there's 10, 12 cases on, and I'm going to spend the time. How long does it take to master this, and how long does it take to do each case?
Excuse me.
So, how long does it take to master this skill to be able to do this?
A skill?
Distal crossing, and how long does it take for each case?
Okay. And from Japanese registry, we can cross the distal optimal cell about 70% probability. And the second case, second challenge, maybe approximately 80 or 90%. We failed to third try, we stopped the OCT.
Is there any data about the clinical difference? I know angiographically or with OCT images you see that. Is there any difference in the long-term clinical outcome? whether you cross the proximal or distal. I appreciate all what happened anatomically and mechanically, but is there any clinical outcome?
Yes, we don't have a clinical outcome, not yet. However, as I explained before, IVUS can reduce the mortality and the stent thrombosis. OCT have more resolution power. So maybe OCT can overcome good result.
Sure.
Thanks, it's a great presentation. And tell us how the bifurcation stenting is actually need to be well thought and well planned. My question to you, in the Japanese registry, what is the percentage that the operators failed to recross? That's number one. And number two, in failure of recrossing, how OCT helped or how OCT failed not to help?
And first attempt, maybe, as I said before, 70% possibility is okay to recross the good point. And if we fail to recross the good position, and we quit to get the good cell, because OCT has need out of contrast amount. So in such a case, we stopped the good cell to choose.
Because my understanding globally, it's about 5 to 10% of bifurcation stenting, especially using a DK crash, you are not able to cross.
So in the expert hands who created this, it was 7%, they could not cross. In some registry, up to 16 to 17%, they could not cross. And I suppose sometimes we have to be a little bit pragmatic rather than dogmatic in what we do. And yes, it's perfect to be able to do the OCT and to do it, but this is ultimately is the clinical outcome. Does it make any difference spending 2 hours trying to, because OCT with its high resolution shows us a lot of information that we don't see on IVUS. So it's how you react to it. But I think, you know, it's a great method of learning the anatomy, learning what happens. And to be honest, quite often for the junior doctors where you teach them OCT to see the resolution and then you move them onto IVUS and then they understand IVUS quite much more.
Yes.
Thank you very much. It was an amazing talk. My question is, in terms of your 3D OCT technique, would you do OCT run after every time you recross in the bifurcation PCI?
Yes. If the patient didn't have a renal function, is good. We'd like to do bifurcation PCI with OCT guidance, especially left domain. Yeah.
Okay, thank you very much.
Thank you very much.
Very elegant cases. Thank you for those who stayed behind. I know it's lunchtime. Thank you.